Okay, thank you so much, everybody, for taking your seat. I'm Dr. Amity Quinn. I'm reading this on my notes. You'd think I knew this already. I'm a health services researcher here at University of Calgary, and I have the privilege of moderating this next discussion called What We Measure, We Change. This session will explore how limits in data and measurement in women's and reproductive health shapes the care people receive, and what happens when something isn't counted. When we fail to measure conditions like menopause, prolapse, infertility, or access to contraception, we not only limit our understanding, we limit improvement, funding, and accountability. Today, we'll hear from an extraordinary group of researchers and clinicians who bring unique perspectives across the reproductive life course, from fertility and miscarriage to menopause policy and data systems. Let's begin with introductions. Okay. I'm just going to go in order. Let's see. Dr. Amy Metcalfe, sitting next to me, is a professor in the departments of obstetrics and gynecology, medicine, and community health sciences at the University of Calgary, director of the maternal and child health program at the Alberta Children's Hospital, and director of maternal and child health program at the Alberta Children's Hospital Research Institute. Her work explores pregnancy outcomes, postpartum care, and long-term health trajectories for women. Next to Amy, we have Dr. Laura Schummers, who we'll hear more from later this afternoon, an epidemiologist and assistant professor in the Collaboration for Outcomes Research and Evaluation of the Faculty of Pharmaceutical Sciences, University of British Columbia. Her work focuses on reproductive health policy, abortion, and miscarriage measurement, and how political and regulatory contexts affect data quality and access. Next to Laura, we have Dr. Amy Johnston, assistant professor in the Department of Obstetrics and Gynecology, University of Calgary, a population health researcher working with administrative data to study women's health across the lifespan, with a particular focus on socio-demographic and intersectional factors influencing those outcomes. And then we've already heard from Dr. Alana Cattapan, Canadian Research Chair in the Politics of Reproduction, and Associate Professor in Political Science at the University of Waterloo. And since she just talked to us about reproduction, she might be focusing more this session on infertility, but we'll see what happens. Okay. All right, so to start us off, please, so this session has no pre-presentations, which we're just going to be doing discussion. So you can just go ahead right now and start inserting questions into Slido. I'm going to start us off by asking a couple opening questions for everybody to get the juices flowing. Right, so Laura, when we say what we measure matters, what does that mean in the context of women's and reproductive health?
I think that's a very broad question, and I'm going to start by answering that in a way that's related to my research, leaving space for people to talk about how that might be different in their areas of research. So for me, one of the things that really stood out in starting to conduct research focused on abortion access is that we really had no solid way of measuring abortion frequency in our health administrative data. So across Canada, our health administrative data is what's used for government surveillance, and it really underpins a lion's share of the research in biomedical, in health services and policy research, in sort of applied epidemiological research. And we're really good at measuring birth. But birth accounts for 60% of pregnancies. And the 40% of pregnancies that end in either abortion or miscarriage before 20 gestational weeks, we basically pretend don't exist for much of our surveillance and measurement work. So over the course of a few years, with a team of clinicians, health services researchers, data geeks, epidemiologists, health service researchers, we tried to really come up with a gold standard approach for how to measure abortion. And it was really complex. It's something that I think we know in this space, the ability to measure abortion frequency often goes hand in hand with abortion regulation. So in settings where abortion, for example, is tightly regulated, it's very well measured because it is basically a reportable health service. For example, in Scotland, anytime an abortion is performed, there is a therapeutic abortion form that must be completed in order for the abortion to be legally allowed, permissible by the health system. In Canada, we are very fortunate to not have that because abortion is a routine part of our normal healthcare, as it should be. But what that means is we kind of fail at measuring abortion. So over time, when the policy and regulatory approaches to reproductive health changed such that abortion became a routine part of healthcare, we lost our ability to do good surveillance. So I think we've made some good strides now in improving those methods. There's some work to be done still in reaching consensus across provinces, across researchers and other organizations to make sure that we're still doing that right. But one area we're still not really doing well on is miscarriage. This is we think common. Again, our measurement varies, so how common it is hard to reliably report to some extent. But even those miscarriages that have a healthcare encounter are often not really reported, and there's no surveillance. So we know how many births there are. We actually don't know how many pregnancies there are in our population.
Thanks, Laura. Okay, Alana, same question to you. When we say what we measure matters, what does that mean?
I think that Erin really, as I said, we should probably just have gone home after Erin's gorgeous remarks, because the idea that what we measure is what we know about, which is what we therefore can prioritize and therefore resource and fund, tells us a lot about what we care about in our society. So when we don't have data about something, again, we have a lot of information about birth, as Laura just said, but not a lot of information about the outcomes for women and their broader overall experience, tells us who is prioritized in those interactions. A lot of my research, as has been mentioned before, is about fertility and infertility care. And we see some of the same kinds of trends there. We know how much, we have a sense, it is a voluntary registry that is owned by the fertility clinics, and I have a lot to say about that. But we do have some voluntary information about the use of infertility treatments in Canada, but we don't have any information about the causes of infertility, about the reasons people come in the door, and certainly we don't have any information about the outcomes for people who use those services, although there is some tracking in Ontario. So it's sort of the same, I feel like we're saying the same thing over and over. What we measure is what we know is the name of the panel. It's also what we prioritize and resource, and if we are not measuring critical issues in reproductive health, we simply can't act on them.
Thank you. Okay. Amy J., where do you see the biggest blind spots in our data, and what are the real-world consequences when something isn't counted?
Yeah, so I think, there's a lot of overlap in the first, couple of responses as well. But, if we don't measure something, if we're not, actively seeking to, increase our knowledge about something, then obviously we're not going to prioritize it. And again, I think this message is over and over. I think there are real world consequences to all of this. So if we don't include women in clinical trials, for example, we see that women experienced about 2 times more adverse events due to, medications. We don't know how to dose it properly necessarily, because what we say is what's applicable in men is directly transportable to women, and so it can really affect people's lives. It can, just simply not measuring it is not just a matter of saying, well, we just really don't understand the burden of this particular illness. It can cause severe consequences and even death.
Thank you. Amy M., same question to you.
So preferences in the context of pregnancy, which is where a lot of my work happens, is the medication piece is real. So like when we look at drug withdrawals that have been taken off the market in the past decade because of adverse effects, 70% of those drug withdrawals have been because of adverse effects in women. That's further compounded when you factor in pregnancy too. People are very scared about taking medication in pregnancy because the data isn't out there to support the safety for the fetus, but also for the woman. And when the woman abruptly stops taking her medication for her pre-existing illness in pregnancy, that illness doesn't go away when you're pregnant, and it still needs medical care. And I think that's also where the big gaps are. We do overall a pretty good job of measuring birth outcomes as it relates to the fetus. We don't do a great job of measuring the consequences of pregnancy for women short-term and long-term, or the long-term implications of that. And we the systems that we have in place to measure other chronic conditions generally fail to account for pregnancy and the role that pregnancy may have in making those conditions sometimes better, sometimes worse, but ultimately I recognize that they have different outcomes. And what that means is that we can't always offer the best evidence-based care to people so that they can have the best outcomes for themselves and the best outcomes for their family, and also just the information for them to make informed choices that are congruent with their values.
Thanks, Amy. Building on that, you've noted that pregnancy outcomes are tracked well, but following up is not. Could you say some more about, I feel like we're talking a lot about this idea today, what that means about how the system values women after that time of their life?
Sure. So what we hear a lot about, pregnancy is a time of high contact health care. You talk about having routine prenatal care where you meet with your care provider, whether it be a midwife or a physician, at recurrent intervals during your pregnancy, and particularly if you have a pregnancy associated illness. So like if you develop gestational diabetes or if you develop high blood pressure in your pregnancy, you'll have even more contact. And there's a lot of focus on your health during that time, but then you deliver the baby and these pregnancy associated conditions go away. They're cured because you've delivered the baby. But these conditions actually have real world consequences for women's lives. People that have gestational diabetes are much more likely to develop type 2 diabetes. I recently had a student who looked at this. In the year following pregnancy in Alberta, the recommendation is that women that have gestational diabetes should go and get a test for type 2 diabetes. 20% of women in Alberta get that test after they are pregnant. 50% get some sort of testing, but only 20% get the recommended testing in that year following pregnancy. And this, again, has a real-life implication for women's lives because the focus of that prenatal care is often on the baby. And again, there are implications for the fetal health, but there's also bigger implications for women's health as they age and they are no longer pregnant as well.
Thanks, Amy. So thinking about across the whole life course here and how you guys have some specific different areas of interest, and unfortunately Natalie couldn't be here to add her menopause perspective, but I will try to bring that myself. What would it take to build data systems that capture women's experiences across the full life spectrum?
I think part of it is, one, asking what are our key performance indicators. So things like, we've talked a little bit about conditions that primarily affect women or conditions that affect women differently. But again, we don't necessarily have good data on these sort of things. We don't have routine surveillance reports. We don't have, and even when data like that exists, we don't use that to prioritize funding or clinical care. We talk a lot about wait time guarantees for hips, knees, and eyes. And again, these things are all important. But again, when you look at the most common surgical procedures in Canada, number one most common surgical procedure, C-sections. Number 3, hysterectomy. These are female-specific surgeries that are in the top 5 drivers of surgeries for all people. So even when you factor that there's a different numerator and different denominator there, these are still more common than other surgical procedures. And the data on that doesn't seem to factor into surgical wait times and OR times.
Does anyone want to expand on that?
I'm going to take the question in a slightly different direction. The question was, what does it take? What would it take to... Do you remember the rest?
It's been deleted already from my iPad.
But what would it take to address some of these gaps in health data to develop better data systems?
Yes.
I think was the gist of it.
And also capture women's
Oh,
experiences.
And capture women's
Across the life
experiences.
course,
All right, well,
yes.
let's
Thank
take...
you.
Okay, that's a lot of things. I'll take a tiny piece. So in the area where I do most of my research, which is fertility and infertility, access to assisted reproductive services, one thing that we've been working on, talking about for, I feel like, generations of researchers now, is a registry that would track the outcomes both for surrogates, for intended parents, for people who carry pregnancies for themselves, for egg donors, for sperm donors, and really importantly, for the children born. And I want to give a shout out to Dr. Juliette Guichon, who's in the room, who's one of the leading scholars on this. I feel really honored to have you here. So in terms of that, the challenge there is that there has been commitments to privacy in those relationships that need not occur, and anonymity of the gametes, so making sure that people don't know who provided sperm or eggs, for example, in those relationships, which provinces and the federal government could simply address that. They could just change that. We could just make sure that people have access to genetically related information about the pregnancies that they're carrying and the children that are born. But there's been a lack of political will to make that happen on the part of the fertility industry, on the part of the government. And there is, and I'm always loath to open up the conversation to talk about federalism, but also federalism is a challenge here. There has to be consensus and political will across the provinces in order to move data as people go from place to place to seek out both maternal health care but also assisted reproductive services. So in my field of research, that is the challenge. Like, what can we do is we can push our policymakers to just start doing the work of coming to agreements that allow us to transfer data and establish registries that move across provinces.
Did you want to say something?
Yeah, I was just going to add something about, I think, in terms of what does it take to improve our data capture. I think there are really, two main types of data that exist federally to track health outcomes, health experiences of our populations. And one I've talked about of health administrative data, where those indicators are lagging is due to poor research funding of these same questions. So when a CIHR grant is funded to study something, whether it, let's say, miscarriage outcomes, then someone is going to do a good job of building a way to measure miscarriage, and then that will go into the ether of a harmonized data approach. The second piece that administrative data cannot answer was part of your question of experiences of care, and that's where we have population surveys that StatsCan puts out. And unfortunately, most of those don't ask great questions about some of these women's health questions. We've had, for example, the Canadian Community Health Survey used to ask about contraception, either initially among married people and then later among youth only, so kind of weird conditional statements. But that was asked, and then those questions were discontinued. So now we have a new survey that will be available in the Research Data Center soon that specifically measures sexual and reproductive health. At the moment, it's a one-off survey. So we can take a snapshot of the frequency of some of these, but we can't see longitudinally how policy or practice change might influence those. So I think we fund research to answer the administrative data sort of building side or registry building side. And then secondly, we use our federal data collection policy or infrastructure to specifically focus on women's health. Like, the infrastructure is there, it's the prioritization that's not.
Yeah, and I think just building on this survey piece too, there are some critical data gaps in questions that there don't ask. And when we don't ask questions, these conditions just don't exist. So for example, Canadian Community Health Survey doesn't ask about PCOS, it doesn't ask about endometriosis, it doesn't ask about any of these other female-specific conditions, which means that we don't talk about them. When we think about administrative health data, there are key gaps. We do not ask about race, we do not ask about ethnicity, we do not ask about gender, we do not ask about sexual orientation, and that allows us to pretend as a society that these factors don't exist and don't influence our day-to-day lives. They don't, in fact, influence our ability to access healthcare or to access culturally and appropriate care, because we don't ask these questions. And that doesn't allow us to think about people as whole people and how all of their experiences and their identity factors influence their lives, because we simply don't ask these questions.
Can I ask a follow-up on that? Because I'm like the sole non-epidemiologist, I think, on this panel. Because one of the challenges we face when we're trying to get data from smaller provinces about fertility care, also about things like maternal mortality, in relation to race, in relation to socioeconomic status, is identifiability in small provinces. And so are there approaches that are being applied in other areas of health where there's a harmonization of data across provinces or across health regions to collect more specific data that also minimizes the potential for identifiability?
Yes. I mean, I think that's built into the infrastructure of all administrative data, where what the researcher sees there could be a risk of re-identification. What is outputted and shared publicly has been aggregated and undergoes another risk of re-identification sort of check. So yes, that requires some trust in terms of what the data, like the analytic environment, who can have access to that. But yes.
Yeah, like we're struggling with that in and around fertility when we're seeing one clinic in certain provinces, for example. Yeah.
Can I just add?
Yes, please.
Yeah, so we want to collect this data and it's important, but one of the points of frustration when I'm doing my own research, and particularly with respect to hypertension and pregnancy, is that we all have different definitions for things, and comparability is so difficult. And it's great for me when I was doing my research in Ontario to define something a certain way. And then when I'm looking to compare with other work done in different provinces and across the United States and Europe and so on, is that everyone defines something differently. So preeclampsia is not preeclampsia. It can be preeclampsia and gestational hypertension in one jurisdiction, but they call it preeclampsia. And so that is a huge point of frustration. And I think it really speaks to the need to work together and to make sure that when we define something, we have a universal definition that is accepted.
Thanks, Amy. How does reproductive health intersect with mental health, and what data should mental health providers be on the lookout for when working with women across the lifespan? Does anyone feel strongly about answering that question?
I'm not equipped.
Send it to Amy J. I will repeat it. Yeah. How does reproductive health intersect with mental health, and what data should mental health providers be on the lookout for when working with women across the lifespan?
Oh, this is a very, very loaded. Yeah, it's so. So my experience with respect to mental health and reproduction is with respect to peer support and peer support programming, and I can bring that lens if that might be helpful. So I think there is a gap from what I understand from working with people who have been part of these peer support programs, postpartum peer support programs, is that women don't want to say that they're having difficulty because they fear that their children will be taken away from them. And one of the things in participating as a co-investigator on this particular program, it was in Ottawa, is that this kind of peer support programming was so beneficial because you didn't need a diagnosis and you could just go and get support you needed. And so I think there is more education that's needed with respect to making sure that women get the help they need, and everything from peer support programming, and not stigmatizing it, I think is so important as well. And I think mental health for women is a big issue that we just don't address very well because of the stigma. So yeah, lots of work to be done on that front.
Thanks. A popular question is, how can we move beyond Band-Aid treatments and towards addressing conditions at their root? So an example provided was like giving birth control for PCOS, not having like a specific treatment option for PCOS.
I think this comes to like the systematic lack of investment in women's health. This is an area, and I'll talk more specifically with the pregnancy context, but I think this applies more broadly. This is an area where there's been such little development from an industry's perspective. When you look at how much money pharmaceutical companies put into research and development, this is billions of dollars. But they do that looking at return on investment. So in the obstetric case, there are 9 drugs that have been developed to treat obstetric conditions. This is the area with the least amount of pharmaceutical development and pharmaceutical investment of all medical conditions. And that also broadly applies to other women's health conditions too. There has not been a systematic investment. When you look at the underinvestment and where this comes through, it's not just in federal dollars, it's also in industry dollars too. And the reason we don't have a specific drug for PCOS and we use birth control for that is because there hasn't been the pharmaceutical investment in R&D to create that specific drug. There needs to be a compelling case and advocacy that there would be a market share piece for this. And of course there would be. Like, it's a very common condition. But the people that are making those decisions about where they're investing their dollars aren't necessarily hearing that there is necessarily a market share for that.
And does that come from the fact that we don't have this in the Canadian Community Health Survey? We don't have good metrics for this. So how would, a pharma exec know this?
Exactly.
I think that it speaks to the concern about things like endometriosis or PCOS being not understood by historical approaches to medicine in relation to quality of women's life, but potential impediment to pregnancy. And so while the treatment for things that might cause infertility is not to potentially address that infertility, but it's largely to seek interventions to circumvent it in order to get pregnant. And so I just want to say 50% around of fertility-related interventions in Canada are related to what is come to be called undiagnosed infertility, Like, that's not a diagnosis. That doesn't tell us about why people are experiencing fertility at the rates that they are. And instead, we're recommending more and more that people have access to infertility interventions that don't address the root cause. I feel like the same thing is true with PCOS and endometriosis, where the approach is, how can we sort of like push you through to address potential future fertility, as opposed to addressing the underlying condition and the ways that it's affecting your life.
And I think it also comes down to, again, like there's a fundamental biological questions about these conditions that we don't know. Again, I'll talk about the pregnancy space. We actually don't know what causes somebody to go into labor. From a biological standpoint, we don't know what causes normal labor, let alone atypical premature labor. Like, birth is a universal experience. All of us in this room resulted from being born. And the fact that we don't know what leads to what the biological cascade leading to birth is mind-boggling, that in 2025 there has not been enough investment in discovery science to understand this universal human experience.
Do you think that's related to the decreasing investment in discovery science and the increased focus on commercialization in scientific discovery?
That's also an excellent question. And I will say there has been systemic lack of funding for that, but I think there's also priorities for this too, right? Because when you look at the CIHR budget, still the vast majority of the CIHR budget does go to discovery-based science. And the questions about this, about basic biological processes, are generally not going to be funded by industry, because industry has a different priority with that. Like their interest isn't in this understanding the natural history. Their interest is in understanding where can I develop an intervention target that I can go sell. And there's value in that. Like that's why we have medicines, that's why we have devices, and that's what we use to treat disease. But there's also, we need an understanding of basic biology so that we can understand potentially where those targets may be to intervene when things don't necessarily go according to the natural course.
And just adding to that briefly, a lot of that discovery science is in male animals, almost all. Yeah. And so that sounds fine. Like, why do I care about female mice? Well, because the physiology of male and female mice might actually mirror male and female humans. And so having all of that discovery science, assuming transportability once again from male to female animals, including humans, does not work.
But I think that even goes further to cell lines and, really using male cell lines. And we've discovered, maybe we should incorporate female cells. So, yeah.
Mm-hmm. Yes. So this is all feeling like it's even a bigger question than what we're measuring. It's like what we're asking questions about and beyond. So with that in mind, if we have to pick a level, whether federal, provincial, municipal, which systems do we put pressure on first to get better data collection on women's health? Do we need an healthcare admin data or national surveys like StatsCan or provinces, or that provinces can conduct? I'm going to ask Laura to start with this.
I think this is federal. I think this starts at the federal level. That is how we measure the health of Canadians in general. That is, StatsCan, CIHI, Health Canada as a whole. They have, this is within their lane. They do this already, and that is where the measurement starts. It will roll out into provinces, which it will include things like provincial health services data, but it starts at the federal level.
Anyone have another opinion?
I mean, it's like asking who your least favorite child is. The way that health priorities in Canada are set generally come from either the province or either the federal government with large purse strings to direct provincial interventions, or from the provinces. But again, we're in Alberta today, provinces don't love being told what to do, and so federal attempts to collect data or to control things typically go awry. I think this has to be a joint effort between federal and provincial governments, led by experts in the field.
Great. Okay. Where do I want to go here? I'll ask another question for Laura. You mentioned the comparison between Scotland and Canada. Is there, if we're thinking just about Canada and the intersection of policy and data around miscarriage and abortion, how do politics shape what we can and cannot measure, and how do we navigate that responsibly?
Yeah, I think the shift of policy and regulation for abortion means that now we measure abortion like any other health service. And so we don't have mandatory reporting, we don't have a registry that will just be auto-populated, and that's actually a success. there isn't really a reason to have a registry of all people who have an abortion, just like there is not a registry, we don't need a registry for all people who took an antibiotic or who, had hypertension. So I think that this now seeps into our health services measurement more generally. For miscarriage, this is something that generally just occurs physiologically. And so once again, this is not even a health service. It is just a health experience that we sometimes measure if that health experience presents to healthcare providers and then makes its way into our fee-for-service billing. So the politics of abortion have changed our measurement and enable us to now measure things differently. I'm not sure if anyone wants to add to that here, but
I actually do. So I'll say that we've tried to measure abortion access in other provinces as it relates largely to we did a series of projects on cancer and pregnancy, and abortion was a key part of that.
Yeah.
Where I think the politics come into play is the data access piece. So we did a multi-provincial study, and in some provinces that abortion data was honestly, it was impossible to access because of the protections around, and that was purely a political decision because people obviously get abortions in all provinces as they should. And as that should be a medical decision, but in terms of being able to use that for research and surveillance purposes, there are political roadblocks that are put in place that make that more difficult to study in some jurisdictions than others.
that is definitely true. BC is one such jurisdiction. Although what the interest, that has its own sort of long tail of why abortion is hard to measure and access in BC, and it does have an exceptional status for requesting data and gaining access to data for abortion. But it's not because abortion is considered somehow taboo or stigmatized. It has to do with a data integrity breach story and the risk to abortion providers for safety of their life after there were some homicides targeting abortion providers. So that story, yes, has to do with politics. That data access angle, I think it's time to move on. It's now legislated within the way that BC protects abortion data, that it has a different legislative process than other healthcare procedures. So it is redacted from all population health data unless you get exceptional use permission to use those data. And that is a challenge, although it's interestingly not as politically driven as you might assume.
In today's, staying in this political landscape, in today's evolving political landscape, how concerned are you about the ways governments might weaponize personal health data, like period tracking apps or gender identity records, to influence policy, especially in areas like reproductive rights, access, or transgender protections? I'll go to Amy J. first on that.
Yeah, it's a huge point of concern. I think if you have a cell phone, likely you know that Big Brother is watching you. And one of the concerns that I have about all of this is we don't know what we don't know. We don't know necessarily what is being collected and how it's being used. And I think we've seen in other jurisdictions that I think we'd be naive to think that we are not maybe headed in that direction if we don't really try and push back and make sure that we are speaking up about this, because I think that it may already be in the works. I don't know. But yeah, I have a Fitbit. I have an Android phone and Google's on it, and I would say the things that I worry about are the things that I don't know that I'm sharing necessarily.
Alana, do you have thoughts on this?
Yeah, I think even if you do know what you're sharing, where our data is held is really important as well. There's brilliant researchers. I'm thinking of Pamela White in the UK, who is doing research on where our data is held, how it's shared, and particularly on period trackers. But all of the information we accidentally or intentionally share with our social media, with our phones, with the devices we carry around with us, with Fitbits, et cetera. Do you know where your data is being held, how it's transferred? And I think that as public health professionals, this might be something those of you who are, I know you're not all public health professionals. I keep calling on public health professionals, but also researchers and people who engage in the education of the public around health. This is something we need to be paying attention to, not just what information is collected, but collected by whom, for what purpose. I think, for example, of the resale of data related to 23andMe, that your genetic information, if you ever use that service, might be sold to the highest bidder. That is a cause of concern. And so when period trackers are being developed, is that data being held in a jurisdiction that you're comfortable with? Is that data held solely on your phone in a relationship between you and your cell phone provider? These are questions that need to be more substantially at the fore if you're to use these kinds of devices. I am new to having a phone for all kinds of just slow to the game reasons, but as a result have been really thoughtful about what apps go on. And because I was so slow to phone use, I'm slightly terrified every time I accept those terms and conditions. And as a researcher, truly do read them. And we probably need to share less. Probably, definitely.
Thanks. On sort of a similar note, sorry, I'm just trying to reword this question. Is considering lack of funding and gaps in care for LGBT2S plus healthcare and research, in the connections between this area and sort of broader women's female reproductive health and treatments like hormone therapy and gender inclusive care. What are your thoughts on how that area, I think, mirrors and is connected with this, or concerns on data and measurement in this area? Think about transgender and
Sorry, what is
policies.
the question? Can you say it again?
Confused. I'm trying to
to
navigate the comments. I think what is your thoughts on how this conversation we're having is kind of mirrored by funding and treatment gaps in LGBTQ+S healthcare and research? Laura.
Yeah, I mean, this is something, certainly in administrative data, we don't know the answer to this question. These are not measured. Just similar to race or ethnicity, these many individual characteristics drive our access to health services and therefore our health outcomes. And this is no exception. That's certainly true. I think this gets back again to our survey questions. And so in our Canadian health survey environment, there are questions asked about LGBTQS sort of membership or self-identification. But if we're not simultaneously asking about all of these other health experiences, whether it's menopause treatment, how does menopause treatment and care work in this group? What about endometriosis and PCOS? And what about contraception and other reproductive health or pregnancy-specific services? Yes, it's important to ask the frequency of Canadian self-identification with groups that have worse access to health services, but we have to also ask that in such a way that we can then look at differences in the frequency of these outcomes and adequacy of care that's received to manage and treat these outcomes.
Go ahead.
I was just going to say on a point of maybe good news, some individuals here in Alberta did validate an administrative case finding definition to identify transgender people in the administrative data. So I plan on using that in my own research. Nothing's ever perfect, but I think we need to make small steps. So I'm really encouraged by that.
Yeah, and I was just going to add, the same recently happened in Saskatchewan. I'm part of a research team that works with folks in Saskatchewan on access to gender-affirming care and navigating the healthcare system. And strangely, in some of the provinces, we do actually have a lot of information because most of the people accessing gender-affirming care go through a couple of physicians or a couple of psychiatrists. And so by talking to those supportive physicians and psychiatrists, we have a sense of the concerns and can extract data with the consent of their patients or with the consent of their health service. That's not great. It should be harder to get. It should be harder to get because the same kinds of hormones that are that should be prescribed to people seeking gender-affirming care can be prescribed by family doctors and are prescribed by family doctors all of the time for menopausal treatment and other hormone therapies. But strangely, for data collection, in Saskatchewan at least, it was really talking to 4 people to figure out who the general population was.
Interesting.
3 or 4.
Thinking about these groups that are often excluded because we don't capture their data, how can we advocate for ethical data collection in these groups, like finding more information on race and ethnicity and transgender identity in these data when there might be concerns about like how the data will be used?
I don't think there's a perfect answer to this. I think it's a really complex area. And like, I fully understand why people don't necessarily want to disclose individual things about their personal identity because they're worried about what the repercussions of that may be in terms of their ability to access care and be safe in their environment. But then by the same time, by not asking those questions, we also then can't do better for populations of people because we don't know. And like, I think we saw this play out in real life in COVID. Like, we obviously know that there were different population groups that had a much higher rate of disease and a much higher rate of poor outcomes. But that meant that because we didn't collect critical data about intersectional factors that influenced like why people got COVID, then we couldn't do targeted population health campaigns or targeted clinical campaigns to minimize risk in those populations that may have different needs and might need different strategies. So like it's a balancing act. And I think part of this comes down to like knowing why we collect data, knowing what we use it for, and being able to collect some data that can be used for a population level versus individual care, and recognizing that there's different things that you need in those different spaces.
But also, like, on the one hand, I recognize that there are large-scale health data systems, administrative health systems and administrative data systems where this data occurs. But in the case of the group that I work with in Saskatchewan, it was the community themselves who came to researchers and said, we need to know, like, we need to collect this data, help us collect this data. And we got funding to fund them to collect this data with our support to design studies and supports that would work to find out what the sort of information they wanted was. And so I guess a short answer to this question is fund the communities who are underfunded, who are vulnerable, who are experiencing adverse effects, who we suspect are experiencing more than the general population in relation to race, socioeconomic status, gender expression. When we suspect that there are health effects occurring in a population, fund that population to collect their own data. They know what they need, and they also know what's occurring on the ground. They're the best people to design the study in collaboration with researchers who can guide the kinds of numbers that we need.
And one thing that I would say, and that's I've kept with me, I've worked in the disability community, and I have a friend who, a close friend, has a disability, and she told me there should be no research about us without us. And I never forgot that. Just like, I'm doing endometriosis research, why would I not include people with endometriosis? I don't have endometriosis. So, it's just something that has always stuck with me. And that's not just about involving people with lived experience, but it's about making sure that we have diverse research teams. Mm-hmm. And that includes not just women, and obviously we need diverse research teams in that capacity, but also involving men as well. So that's something that I'll always keep with me.
Thanks, Amy. Amy, you shared a note of hope. Thinking as we wrap up this session, looking forward, Laura, what gives you hope in this space?
I mean, I think we've made really big strides here. So I can see that as we continue to fund women's health research and the health of all people with respect to reproduction and beyond, that increased funding will mean we'll continue to do a better job in measurement. And then we can partner with policymakers to drive that change and use those levers to influence health outcomes.
Amy M., do you have any hopeful notes?
Yeah, I think the conversation is changing. I think today's like this matters so that we can have these conversations in a public space. But I also think the conversations are changing on a national and international scale too. Like certainly in the clinical trial space, we're seeing new international recommendations about the inclusion of pregnant and lactating people, recognizing that these people also need access to medications and should be, and like moving towards a policy of inclusion as opposed towards policies of exclusion. But I think there's still big strides, but I think we're taking the right steps.
Thanks, Amy. Amy J., if you could add one new national indicator tomorrow to advance women's health, what would it be?
Two?
Sure.
So I think, as people have mentioned, I think it would be what we need to know, from my perspective, is information on age at menarche and menopause. Those would be key things that I would say.
And Alana, what indicator would you add to wrap this all up?
I've already gone on my long rant about infertility indicators, but I want to give a shout out to my brilliant doctoral student, Eleanor McGrath, who's doing research on maternal mortality data and severe maternal morbidity data. We do not have good data about what are called maternal near misses, where people almost die in pregnancy. It's not tracked nationally. She's doing research about why that's the case. And so in both tremendous respect for her research, but also because I think it's hugely important, I think severe maternal morbidity data would be really useful.
Awesome. Well, thank you all for your insights, and to the audience for your engaging questions. I think we have a lot of work to do, but it's nice to know we have some hopes and direction moving forward. And I'd like to introduce Dr. Rabia Jalil, who will lead the next session of rapid fire presentations and a panel on female reproductive health access for vulnerable groups. Thank you.